Next chapter, stomach and duodenum. One of easy chapter for you because it's one of the final year case for you during your final year practicals. You have discussed peptic ulcer, cancer, etc. So let us discuss cancer stomach now and peptic ulcer in this chapter. Before going into the proper surgical point, I want you to know about two important things. One is vagus nerve, another is H. pylori. Okay. So this is left vagus nerve runs anterior part of stomach. On the anterior wall of stomach runs the left vagus nerve. So it ends on the pylorus like a crow's foot like this. Therefore, this is known as crow's foot or nerve of lateral. It's known as nerve of lateral or crow's foot. It's known as nerve of lateral or crow's foot. So it runs anteriorly. And we have gastric branches like this. We have gastric branches from left vagus nerve, and left vagus nerve also gives hepatic branches. This is hepatic branch. So these are the branches of left vagus nerve. What I have drawn shown here in green color is left vagus nerve. So left vagus nerve runs anterior or posterior? It runs anteriorly. So now comes the posterior vagus nerve. So please remember, left vagus nerve is a thin nerve, but posterior vagus nerve is a very thick nerve like this. It is palpated like a guitar string. It runs right side. It runs right side and posteriorly like this. It is running right side and posteriorly like this, and it also ends on the posterior wall of stomach like a crow's foot. It is also known as crow's foot or nerve of lateral. So please remember, this other name for crow's foot is nerve of lateral. This also gives gastric branches. This gives a branch to the celiac plexus branch, and very important image-based question asked in FMG exam is this. This is one branch coming from posterior vagus nerve supplying the fundus like this. From the posterior vagus nerve, there is one branch running and supplying the fundus. This branch is known as criminal nerve of Grassi. Criminal nerve of Grassi. Why it is known as criminal nerve? Because when we do truncal vagotomy at this level, this fellow escapes, and therefore it causes recurrent ulcer in the fundus like this. That is why it is known as criminal nerve of Grassi. So from this image, please remember the branches of posterior vagus nerve. Posterior vagus nerve branches are CCC. Celiac branch, criminal nerve of Grassi, crow's foot are the three C branches of posterior vagus nerve, and there is another branch, gastric branch. So in this, I want you to understand two operations related to vagus nerve. One is truncal vagotomy. So please understand what is the reason I should discuss this topic in this chapter is because vagus nerve is the main nerve to stimulate acid production. So in a patient who is having increased acid production due to getting peptic ulcer, we will do truncal vagotomy. Truncal vagotomy is done at the level of trunk of the vagus nerve on both sides. We will do it at the level of trunk at this level. So as you cut the trunk, you can see naturally all the branches are gone. All the branches are gone. But our purpose is what? Our purpose is to reduce the acid from these gastric branches. From these gastric branches, we have to reduce the acid. But since it is very difficult to cut only the gastric branches, olden days, the surgeons, even now, we cut the vagus at the trunk. So this procedure of cutting the vagus nerve at the trunk is known as truncal vagotomy. And it has a list of complications we are going to discuss now. And if I cut the vagus branches, only the gastric branches, that is known as high selective vagotomy, also known as parietal cell vagotomy, which supplies the parietal cells to the stomach. That is known as high selective vagotomy or parietal cell vagotomy, which is supplying only the stomach. So high selective vagotomy or parietal cell vagotomy, that is known as high selective or parietal cell vagotomy. So please don't forget these two major surgeries. So now please understand when I am going to do truncal vagotomy. Truncal vagotomy, if I am going to do, naturally see what are the damages I am going to cause without our knowledge. So we are going to cut the hepatic branch. Hepatic branch is very essential for gallbladder contraction and for bile secretion. So as you cut the hepatic branch, there will be bile stasis and formation of gallstones. Similarly, when I am going to cut a trunk, there is going to be loss of crow's foot. The function of crow's foot or nerve of lateral. What is the function of nerve of lateral? Nerve of lateral has a function. The function is known as that nerve of lateral has a function. That function is to open the pylorus. So please remember, pylorus relaxation is the function of crow's foot. If I cut the pylorus goes for pylorospasm. So that is physiologically obstruction happens because of the loss of crow's foot. So the problems happening are gallstones, pylorospasm, and there is diffuse atonicity of stomach. Diffuse atonicity of stomach. All these are the problems happening with truncal vagotomy. So in olden days, to prevent gallstones, they used to do cholecystectomy also, but it is not done now. But however, there is after truncal vagotomy, you can see there is pylorospasm. The foot cannot go. There is a pylorospasm here. How to rectify this problem? So after truncal vagotomy, therefore we need drainage procedures. We have to do drainage procedures. The commonly done drainage procedure is GJ. This is what we commonly do in our practice. So we will do gastrojejunostomy. After truncal vagotomy, we do a procedure known as gastrojejunostomy. This is the procedure we commonly do in our practice. Is there any other option? Yes, there is one more option, that is truncal vagotomy with this pylorus will be opened horizontally and will be closed vertically like this. Will be closed vertically like this. This is known as Hinke-Mikulicz pyloroplasty. Hinke-Mikulicz pyloroplasty. Pyloroplasty. Either we have to do truncal vagotomy with GJ or we have to do truncal vagotomy with Hinke-Mikulicz pyloroplasty, where the pylorus is opened horizontally and it will be closed vertically. That is known as Hinke-Mikulicz pyloroplasty. So these are the options for truncal vagotomy. So to avoid these type of drainage procedures, we can only cut the gastric branches separately like this. If you cut only the gastric branches, there will be easy. No need of any drainage procedure. That procedure is known as high selective vagotomy. High selective vagotomy, no need of any drainage procedure. Please remember, no need of drainage procedure if you do high selective vagotomy. So please understand there are two procedures, truncal vagotomy with gastrojejunostomy and truncal vagotomy with pyloroplasty. So now we are going to discuss about the complications of truncal vagotomy and GJ. Okay. So complications of truncal vagotomy with GJ. So this is an essay question for final year students. So please understand clearly. Already told you the complications of truncal vagotomy. They are gallstones. Complications of truncal vagotomy are gallstones, post vagotomy diarrhea, atonicity of stomach, and pylorospasm. In this, the most worst complication is pylorospasm. To prevent that, we do the GJ, and because of GJ, we have a list of complications. So due to GJ, if you see, this is gastrojejunostomy. So due to GJ, we have some syndromes happening. So please remember, this is afferent loop. This is efferent loop. Efferent loop means carrying food particles from the stomach. Afferent loop is the one which carries bile and pancreatic juice towards the stomach, and this is efferent loop which brings the food particles out like this. So now understand the syndromes which I am going to tell you. There are three syndromes I am going to explain for you. One is malabsorption syndromes. Malabsorption due to GJ, one syndrome I am going to explain. Another is dumping syndrome, I am going to explain you. Dumping syndrome. And I'm going to explain you one more syndrome, loop syndrome. So these are three syndromes I'm going to explain you in detail. Malabsorption. So because of GJ, you can see the food particles containing iron, calcium gets absorbed more in the duodenum. Iron and calcium gets absorbed in the duodenum. So they are not absorbed now well. So they directly go here. Therefore, you can see iron deficiency anemia is the most common complication of gastric surgeries, especially after gastrojejunostomy. The most common complication is iron deficiency anemia. And you can also see calcium deficiency resulting in osteoporosis and long term. Osteoporosis may happen on long term. And these cases may also have B12 deficiency. B12 deficiency anemia is also seen. So iron deficiency anemia, vitamin B12 deficiency, calcium deficiency leading to osteoporosis are all various complications due to bypassing the duodenum. Okay, so please remember malabsorption complications. And coming to loop syndromes, there are two loops I told you. This is afferent loop, this is efferent loop. If the afferent loop gets obstructed like this, what will happen? Just think logically. If the afferent loop which is going to carry the bile and pancreatic juice is obstructed like this, the bile and pancreatic juice gets stagnated after eating. If you eat a food, for example, you are eating a piece of butter naan, the butter naan will go freely like this. Butter naan will pass down to the jejunum. But what will happen? The butter naan will pass out, the bile and pancreatic juice will remain in the duodenum, and there will be distension happening here. And patient will complain of pain, and suddenly they will have the pylorus will open back and the bile and pancreatic juice will be vomited. So afferent loop syndrome is characterized by severe bilious vomiting with food or without food. There will be severe bilious vomiting with the no food. They will have severe bilious vomiting with no food in afferent loop syndrome. And please remember, among the two syndromes I'm going to discuss, afferent and efferent, afferent loop syndrome is most common. And please don't worry about afferent loop syndrome. Most of the time it will become self-limiting. It will become alright by itself. It is usually due to kinking of the afferent loop. This loop is very lengthy. The afferent loop is lengthy, so it gets kinked or it gets twisted and result in this syndrome. Okay, most of the time it will become alright slowly. But on the other hand, efferent limb syndrome is very dangerous because the obstruction is over here. As obstruction is in the down pathway, the food and bile cannot go down, and there will be severe vomiting of food along with the bile. Food and vomit, everything will come out. That is known as efferent loop syndrome, and this is an emergency. It is like an intestinal obstruction. Therefore, emergency surgery should be done for efferent loop obstruction. So please don't forget about afferent loop and efferent loop obstruction. Afferent loop obstruction is very common. Nothing to worry. It may sometimes resolve by itself. Efferent loop syndrome is most serious. It is due to various reasons, especially like obstruction or kinking, herniation, etc. But whatever it may be, efferent loop obstruction is an emergency, needs immediate surgery. Okay. So, and I'm going to explain you the third syndrome, dumping syndrome. High yield for your exam. High yield exam question. Dumping syndrome, also known as what? Dumping syndrome, also known as post-Siebel syndrome. Dumping syndrome or post-Siebel syndrome, after eating syndrome. So dumping, you all know dumping things. So as you eat, you dump the food inside. So that is the main principle behind this dumping syndrome. Please understand what is going to happen in dumping syndrome. Now let us assume this fellow had an operation, truncal vagotomy, GJ done. He is going to eat 3 butter naan or roti is eating. Okay, 3 roti is eating. After he eats 3 roti, immediately what happens? All the 3 roti, instead of being crushed into pieces in the stomach, since there is a big lumen, it will immediately go to the jejunum like this. Directly. Okay. It goes into the jejunum like this, and since this roti is hypertonic, what it will do? It will try to absorb the fluid from the body. All the fluid from the body will be absorbed into this hyperosmolar food particles will absorb the fluid to become isotonic. That will cause what problem? That will cause within half an hour of eating too much of food particles, too much of food if you eat, within half an hour, patient will have fluid shift and have hypovolemia. This is known as early dumping. This is purely due to fluid shift, and therefore patient complains of dehydration and giddiness. So giddiness and dehydration will be complained by the patient. Early dumping within half an hour of eating. So after some time, the hypertonic fluid particles will release sugar into the circulation in enormous amount. So this enormous sugar will go and stimulate the pancreas. And pancreas will release enormous amount of insulin, and that insulin will come and neutralize the sugar. This will take 2 hours. This is known as late dumping. In 2 hours, enormous insulin neutralizing the sugar result in reactive hypoglycemia. Reactive hypoglycemia is the reason for late dumping. So please understand, very simple. Early dumping, food goes down, absorbs fluid and becomes dehydrated. That is early dumping in half an hour, which can be diagnosed when you measure packed cell volume or hematocrit. When you measure hematocrit or packed cell volume, you can find out early dumping easily. Late dumping is diagnosed by measuring postprandial blood sugar, which will be low. After 2 hours, usually there will be sugar high, but these guys will have low sugar. So easily diagnosed by postprandial blood sugar. So for your exams, the question will be early dumping is due to hypovolemia, late dumping is due to reactive hypoglycemia, early dumping measured by BCV and hematocrit, late dumping diagnosed by postprandial blood sugar. Now the question comes in, how to prevent this dumping syndrome? Very simple. 4 instructions. Give the patient 4 instructions. Number 1, tell them all the butter naan belongs to him only, nobody will eat. Ask them to eat one by one. Slowly. Ask them to eat slowly one by one. Okay? Within a gap of half an hour, 1 hour, like that. Ask them to eat small frequent feeds. Small feeds should be taken. 2, they have to take low carbohydrate diet. Ask them not to take more carbohydrate. Let them take low carbohydrate diet. Ask them to take high fat diet. Okay? So small meals, low carbohydrate diet, high fat diet. Avoid drinking water while eating. Some people, what they will do after eating a small piece of food, they will drink water. As they drink water, that food will move fast into the jejunum. Water will come in the urine, and all the problem will happen. So therefore, avoid drinking water while eating, not afterwards. While eating, don't drink water. Okay. So ask them to take dry meals. In other words, ask them to take dry meals. So dry meals, small meals, low carbohydrate, high fat is a prevention of dumping syndrome. If already dumping has happened, how to treat them? Already dumping has happened, we treat them. Early dumping, advise them to silently lie down for a few minutes. It will become alright within some time. Lie down for some time. Late dumping, advise them to take some more sugar. After 2 hours, ask them to take some sugar. And advise them all these instructions. If they are alright with this, no need to worry. If not alright, we have to give drug of choice. What is it? The drug of choice for dumping syndrome is octreotide. The dumping syndrome, drug of choice is octreotide is a drug of choice. Most of them will be all right with octreotide. If they are not all right with octreotide, we will do revisional operations, which is beyond the scope of PG. So revisional surgeries will be done if there is no cure with octreotide. So please remember, dumping syndrome is a very important syndrome. So the point you should not forget is related to complications of truncal vagotomy GJs, truncal vagotomy related complications, gallstones, post vagotomy diarrhea, atony, GJ related complications, malabsorption, dumping syndrome, loop syndrome. High yield MCQ for your exams. To avoid all these complications, what we can do? We can do a simpler operation but not done commonly. That is high selective vagotomy. High selective vagotomy, in which we cut only the branches entering the stomach using special microscope. Look, microscope we have to use and cut only the gastric branches. And we will preserve the crow's foot. Naturally, since crow's foot is preserved, no drainage needed, no pylospasm, no gallstones, no dumping syndrome. But what is the problem with this high selective vagotomy? Why we are not doing this? The only reason is it has 10% recurrence rate. The recurrence rate of high selective vagotomy is 10%. That is why we are not doing this operation. Okay, so high selective vagotomy, where will you start the cutting of the branches? It is 7 centimeters. We have to leave the pylorus. 7 centimeters proximal to the pylorus, leave the branches, and after that start cutting the branches entering like this. So the high selective vagotomy, the distance from which the nerves are cut is 7 centimeters onwards. We have to cut. In high selective vagotomy, there is no complication like dumping syndrome, no complication like loop syndrome, etc., etc. Therefore, high selective vagotomy, those. Now the good operations in India, we don't practice high selective vagotomy. Usually we do only truncal vagotomy with GJ. Okay, usually we do only truncal vagotomy with GJ in our patients. Okay. So I hope you understood about the vagus nerve branches and the vagotomy procedures. Okay, vagus nerve branches and vagotomy procedures go hand in hand for understanding. So please understand it. And before entering this chapter, let me discuss about the hero of this chapter, Helicobacter pylori. The hero of this chapter is Helicobacter pylori. Let me discuss you. There are so many MCQ points from Helicobacter pylori. The first point is from microbiology. It is gram-negative carcobacilli. It is gram-negative carcobacilli with a Lophotrichus flagella. The flagella which I have drawn there is Lophotrichus. Multiple flagella on one side. It is motile organism, freely motile, and it resides only in gastric epithelium. Very important point. It can live only in gastric epithelium. So therefore, where are the habitat of this organism? It is in stomach. It is in metaplastic duodenum. Stomach metaplasia, gastric epithelium metaplasia of duodenum. Metaplasia in the duodenum. Meckel's diverticulum. It can be seen in Meckel's diverticulum. So stomach metaplasia of duodenum, Meckel's diverticulum, and it can be seen in even ectopic mucosa, ectopic gastric mucosa of rectum also it can happen. So wherever there is gastric epithelium, H. pylori can attack. Otherwise, H. pylori will not go that place. Okay, H. pylori is a freely mobile organism. It is specifically involves only gastric epithelium. Okay. Special properties are it produces an enzyme urease. It is urease positive, catalase positive, and oxidase positive on microbiology examination. All these are positive, and this urease positive is used as a diagnostic protocol. And because of this urease, it produces ammonia from the urea. By splitting urea, it produces ammonia and maintains local alkalinity. Around the organism, there will be alkaline atmosphere, and because of local alkaline atmosphere, there will be persistent acid stimulation seen. This is one important reason for increased acid production by the organism. By maintaining local alkaline nature, it stimulates acid production. Okay, and it produces some toxins. They are VAC-A toxin and CAG-A toxin. Already told you, CAG-A toxin stimulates distal gastric cancer. Please remember, it is not associated with proximal cancer, only with the distal gastric cancer. It inhibits esophageal adenocancer and proximal gastric cancer. So please remember, it protects people from proximal gastric cancer and from esophageal adenocancer. It is inhibitory. Okay, its relation with squamous cell cancer of esophagus is doubtful. Squamous cell cancer of esophagus is doubtful, not so clear. You don't know whether it is really associated or not. Is so clear. Okay, so now let us assume if a patient comes to you with a gastric symptoms, peptic ulcer symptoms, the patient is coming to you. You want to find out whether he is having H. pylori positive or not. We have to do what is the investigation of choice to diagnose H. pylori is present or not. Answer is ELISA, simple test. ELISA or serology for H. pylori. It is a non-invasive, simple test, non-invasive test. We can say whether it is positive or negative. But at the same time, for this patient, you are going to put an endoscopy. If you are doing invasive investigation, if you are going to put an endoscopy, investigation of choice is what? When you put an endoscopy, you can take biopsy from the stomach, some here and there, and we can put that biopsy on a slide containing a test known as rapid urease test. So this is a kit like a urine color. There is a kit I will show you in the image. Rapid urease test. We have to put that tissue on that slide. Immediately, if it is positive, it will change into pink color. So this is a rapid urease test is the investigation of choice. If you do endoscopy, if no endoscopy, it is ELISA. So please understand, in developing countries like India, the incidence of this organism is around 60 to 80% of us will be having positivity. So once they have symptoms and once it is positive, we have to immediately start them on triple drug regimen. Triple drug regimen is started for them, for the patients. The regimen is lansoprazole, lac, amoxicillin, clarithromycin for 7 days to 14 days. Lansoprazole, amoxicillin, clarithromycin, lac regimen, which is US FDA approved regimen. Lansoprazole, amoxicillin, clarithromycin is a US FDA approved regimen for 7 to 14 days. OM regimen, omeprazole, amoxicillin, metrogyl is another regimen which is 7 to 14 days. Indian regimen, omeprazole, amoxicillin, metrogyl, cheap cost but highly non-palatable regimen. So latest advice is to use only for 7 days. How long you should give H. pylori eradication therapy is for 7 days is the latest recommendation. So latest recommendation for giving triple drug regimen for H. pylori is for 7 days. So now let us assume after 7 days the patient comes to you back. He wants to know whether it is eradicated. So investigation of choice to look for eradication of H. pylori. He wants to know whether H. pylori is cleared or not. Eradication. What is investigation of choice? To look for eradication of H. pylori, it is C13, C14 urea breath test. So please remember, to look for eradication, C13, C14 urea breath test is the investigation of choice to look for eradication according to textbooks. Now recently new investigation has come to look for eradication. What is it? So this is an expected MCQ, stool examination for H. pylori antigen. Stool for H. pylori antigen is a recent investigation to look for this organism. Stool for H. pylori is the recent investigation to look for H. pylori antigen. So please remember this point. So investigation to look for eradication is C13, C14 urea breath test. as per textbooks, and recently newer investigation is to look for stool for H. pylori antigen. If you ask you an exam, what is the gold standard to diagnose H. pylori? Gold standard to diagnose H. pylori is staining and culture. We have to stain it and do culture and sense culture for this organism. Can you tell me what is the stain used for H. pylori? Special stains: silver starry stain, Giemsa stain, Warthin starry stain. All these are special stains used for H. pylori. So silver starry, Giemsa, Warthin starry are the stains used for H. pylori. To diagnose H. pylori, we use special stains for this organism. Okay. And finally, if you see, what are the questions asked? What is the investigation of choice to diagnose H. pylori? Is serology in a non-invasive way, invasive way, rapid urease test, eradication, we have to do C13, C14 urea blood test, or stool H. pylori. Gold standard is culture. Okay, so now what are the pathology problems caused by this organism? Problems caused by this organism. It causes the list of problems I'm going to list out now. Duodenal ulcer. It causes gastric ulcer. It causes type B gastritis. There are two types of gastritis, A and B. A is autoimmune in nature, seen in pernicious anemia. Type B is H. pylori gastritis, which most of you will be having. Most of us will be having type B gastritis caused by H. pylori. Duodenal ulcer is seen in 90% of the patients positive. H. pylori 90% positive. Gastric ulcer is 80% positive. Okay, and which this is 100% associated, means maltoma is 100% positive for H. pylori. So when you find out maltoma 100% it is associated with H. pylori, please don't forget it. And distal gastric cancer. 6, menetrious disease. Menetrious disease. So duodenal ulcer, gastric ulcer, type B gastritis, maltoma, distal gastric cancer, menetrious disease are the problems caused by H. pylori. Okay, so in this you have to know which are not caused. Please don't forget proximal gastric cancer, it is not associated. Type A gastritis, it is not associated. Okay, and there is diffuse type of gastric cancer. Diffuse type of gastric cancer according to Lawrence classification is not associated. Diffuse type A gastritis, proximal gastric cancer, these are the cases not associated with H. pylori. Not associated with H. pylori. Please don't forget these points. Okay, so type A gastritis is associated with pernicious anemia. It is autoimmune nature. Okay, pernicious anemia, it is autoimmune nature. So please don't forget these points, very important for your exams. So next we are going to discuss peptic ulcer disease. So peptic ulcer. You see, peptic ulcer is divided into two. One is duodenal ulcer, another is gastric ulcer. So let me divide the ulcer into duodenal ulcer and gastric ulcer. So please understand the classification of peptic ulcers. So which is common? Duodenal ulcer is common or gastric ulcer is common? So please remember, duodenal ulcer is most common. It is most commonly found in D1. It is most commonly found in D1. Either anteriorly it can be seen or it can be seen posteriorly. Anteriorly located duodenal ulcer, anteriorly if it is located, if it goes so severe, it can cause perforation. Posteriorly located duodenal ulcers, if it is so severe, it can cause bleeding from the which artery? Gastroduodenal artery. So please remember, duodenal ulcer is seen in the first part of duodenum. Active duodenal ulcer, anteriorly located will cause perforation, posteriorly located will cause bleeding. Okay, this is classification of duodenal ulcer. Very rarely you get in D2 or D3 areas. If at all you see ulcer in D2 or in unusual sites, what you should think of? You should think of what syndrome? Unusual peptic ulcer in the second part of duodenum or in the jejunum and all, you should think of Zollinger-Ellison syndrome. Okay, so we are going to discuss it separately in pancreas chapter, but remember, unusual peptic ulcers are seen in Zollinger-Ellison syndrome. And coming to gastric ulcers, there is a classification of gastric ulcers that is known as modified Johnson classification of peptic ulcers. Modified Johnson classification, type 1 is the most common ulcer. So please remember, modified Johnson type 1 is most common ulcer. Where is it located? Can you tell me what is the most common site of type 1 ulcer? It is in the incisura at the lesser curve. Incisura at lesser curve is the most common site. At the antrum, incisura lesser curve site is the most common site. 2 is 2 ulcers. Where are the 2 ulcers? 2 is 2 ulcers. One in the stomach, another in the duodenum. That is known as 2. Dual ulcers. 2 for dual ulcers. Remember like that. 3 is for pre. Remember like that. 3 pre-pyloric ulcers. Pre-pyloric means over here. Over here it is 3 pre-pyloric ulcer. 4 is an ulcer in the proximal stomach near the lesser curvature area. Proximal ulcers. Where is it seen in the proximal stomach? In the proximal stomach at the lesser curve area. It's seen at lesser curve. Proximal stomach in the lesser curve area. We get ulcer type 4 ulcer. So type 1 is incisura. Type 2 is 2 ulcers. 3 is pre-pyloric. 4 is proximal lesser curve ulcers. 5, that is new classification, modified, they have added 5 NSAID induced ulcers. Somewhere here and there. In the stomach. Everywhere in the stomach you get NSAID induced ulcers like this. So modified Johnson classification 1, 2, 3, 4, 5. So 1 is at the incisura, 2 is 2 ulcer, 1 in the stomach, another in the duodenum, 3 is pre-pyloric, 4 is proximal, 5 is NSAID induced ulcers. Interesting point in these ulcers, all these ulcers classification in this. If you see, duodenal ulcer is purely due to what? What reason? Due to increased acid production. Increased acid production causes duodenal ulcer. So much of acid is produced in the stomach that goes to the duodenum, irritates and forms ulcer. Duodenal ulcer. Gastric ulcer is mainly due to what reason? Loss of mucosal barrier. Please understand, loss of mucosal barrier causes gastric ulcer. Loss of mucosal barrier. It is not due to acid. As per norms, it is not due to acid. The acid is less. In fact, it is very less, and it is usually due to loss of mucosal barrier. Causes peptic ulcer. Loss of mucosal barrier. So now, at this point, one interesting question comes. So gastric ulcer is due to loss of mucosal barrier, not due to acid. But there are 2 culprits in this list. They are due to increased acid. Who are they? They are type 2 ulcers and type 3 ulcers are same like duodenal ulcers. They are due to increased acid. Increased acid producing gastric ulcers are type 2 and type 3 ulcers behave same like duodenal ulcers. Please remember, type 2 and type 3 they behave like duodenal ulcers. Clinical feature, presentation, management, everything is same like duodenal ulcer. Okay, now let us discuss the management of these ulcers here itself. Then only you can understand the mechanism of treatment. So first of all, understand a patient coming to you with a duodenal ulcer and a patient coming to you with a gastric ulcer type 1, type 4, gastric ulcer type 2, type 3. I'm not discussing NSAID ulcer because NSAID induced ulcer, you know the treatment. When you stop NSAID, it will become normal. Okay, therefore, I'm going to tell you that line of management for these ulcers. A duodenal ulcer patient comes to you. What will you do? You have put an endoscopy, you have seen a duodenal ulcer. You will take H. pylori. So if there is an active duodenal ulcer, 8 weeks of either H2 blockers or proton pump inhibitors. We mostly use PPA. After 8 weeks, you can see duodenal ulcer is healed. 8 weeks of proton pump inhibitors will heal the duodenal ulcer. That is the treatment of duodenal ulcer, medical treatment now. So when will you go for surgery in a duodenal ulcer? Indications of surgery in a duodenal ulcer are: number 1, intractable means non-healing of ulcer after 6 weeks, 8 weeks of treatment. Intractable ulcer. Bleeding duodenal ulcer, we do surgery. Perforation of ulcer, we do surgery. And duodenal ulcer going for cicatrization and producing gastric outlet obstruction is another indication of surgery. So there are 4 important indications of surgery in a duodenal ulcer. So indications of surgery are intractability, bleeding, perforation, GO. Can you tell me which is the most common indication for surgery? Bleeding is the most common indication of surgery in a duodenal ulcer. But as surgeons, you have seen more and more of perforations. But the most common indication for surgery is bleeding. Okay, perforation is not a common indication for surgery. Please remember, most common indication of surgery in a duodenal ulcer is bleeding. Okay. Now coming to gastric ulcers. Gastric ulcers type 1 and 4 are not due to acid. It is due to loss of mucosal barrier. Therefore, no use of giving proton pump inhibitors or H2 blockers. So what you should do for them? For type 1 and 4, therefore, we will give sucralfate, ulcer healing agents. Sucralfate will be given. Remove the risk factor. Identify the risk factor and remove the risk factor for these cases. That is enough. And wait for 8 weeks. In 8 weeks, if the ulcer has healed, nothing to worry. Or else what we have to do? Or else we have to do surgery. Why? Why we are doing surgery for a non-healing gastric ulcer? Because very simple reason, there may be an occult malignancy in the ulcer. Therefore, we have to do surgery for non-healing gastric ulcers after 8 weeks. For type 1, we should do wedge resection of the ulcer. Do wedge resection of the ulcer and send it for biopsy. Type 1, we should do wedge resection of the ulcer and send it for biopsy. Type 4. So both these cases are not due to acid. Please remember, type 1 you should do wedge resection. Type 4 we will be doing some named operations which are from Sabiston, not from Bailey and Lowe. So type 4 ulcer is seen in the proximal stomach at the lesser curvature over here. So there are some operations I'm drawing you for your understanding purpose. Please understand this. We will do distal gastrectomy like this with a pouch-like extension like this, including the ulcer. Like this, we will resect the stomach. What is this procedure? Pouch-like. So remember, pouch-like procedure. Pouch-like, just for understanding. Like a pouch is extending, it is known as pouch-like procedure. One more fellow, he's a mad fellow. He left the ulcer there itself and removed the distal stomach like this. He is a mad fellow. For understanding everything, that is Kelling-Madliner procedure. The concept of this operation is Kelling-Madliner thought slowly that ulcer will disappear if you remove the distal stomach. Kelling-Madliner procedure, ulcer is left as such. One more fellow, he did a Sunday procedure. Sunday procedure means for a small benign ulcer like this, he removed this much of stomach. See, this much of stomach he removed. Near subtotal gastrectomy he has removed. That is known as Sunday's procedure. That is known as Sunday's procedure. So pouchet procedure, Kelling-Madliner procedure, Sunday's procedure are the procedures done. Pouchet is pouch-like cut for type 4 ulcer. Kelling-Madliner leaving the ulcer there itself and removing the distal stomach. Sunday removing so much of stomach. After removing all this stomach, we will do what reconstruction. The reconstruction what I am drawing is done for these patients. What is the name of this reconstruction? Gastrojejunostomy is done after all these operations. This is known as, after this we have to do Billroth 2 GJ. Okay, so please remember, type 4 ulcers we will do pouchet, Kelling-Madliner and Sunday's procedure. So this is for, so if you understand, I'm going step by step based on this column. Okay, based on this column, I'm going step by step. Sorry. So you can see we are going step by step based on these options. So now coming to duodenal ulcer, when you do surgery, you know. Type 1 and 4 ulcers which are not due to acid, when you should do surgery, we have understood now. Similarly, for type 2 and 3 ulcers, we will start them on PPI or H2 blockers and review after 8 weeks. If after 8 weeks, if the ulcer is still persisting, what you should do? We have to do surgery. Intractable type 2 and type 3 ulcers, we have to do surgery. The surgery for both the cases is same. We have to do truncal vagotomy first. So please remember, we have to do truncal vagotomy first. After doing truncal vagotomy, we cannot do only GJ because this ulcer may be a malignant ulcer. So what we should do? Do truncal vagotomy, and for either type 2 or type 3 ulcer, do distal gastrectomy like this. So truncal vagotomy, distal gastrectomy, and then we have to do what reconstruction? Again, same way, we have to do Billroth 2 reconstruction is done. So no confusion in this. So for type 2 and type 3 ulcers, since it is due to increased acid, first of all we should do truncal vagotomy. Second step we should do distal gastrectomy. Second step we should do distal gastrectomy. Third step we have to do Billroth 2 reconstruction. This is for type 2 and type 3 ulcers. Very clear cut now. For duodenal ulcer, for bleeding, perforation, intractable GOO cases, we have to do surgery. Type 1 and 4 gastric ulcers, we have to do surgery. 1 we have to do wedge resection of the ulcer and send it for biopsy. 4 we have to do pouchet, Kelling-Madliner and Sunday's. And for type 2 and 3 ulcers, we have to do truncal vagotomy with a distal gastrectomy. Okay. So now at this point, let me discuss about the surgical treatment of each complication of duodenal ulcer. Duodenal ulcer, complication-based management. Complication-based management. First of all, if it is an intractable duodenal ulcer, what treatment I told you? Intractable duodenal ulcer, what is the treatment? So please understand, for intractable duodenal ulcer, the treatment is from Sabiston. He says high selective vagotomy is better answer than truncal vagotomy plus GJ. So though we don't do high selective vagotomy, the answer for this question from Sabiston direct line. For intractable duodenal ulcer, the procedure of choice is high selective vagotomy is better than truncal vagotomy with GJ. So that is from Sabiston. So follow Sabiston for each entrance exams. For a bleeding duodenal ulcer, what you should do? For a bleeding duodenal ulcer, we are going to discuss about bleeding duodenal ulcers separately. Initially, we should do endoscopy. And most of the patients can be arrested with endoscopic adrenaline injection. Endoscopic injection, adrenaline is used. If the bleeding is not stopped with injection pantoprazole, we have to go for endoscopic adrenaline or endoscopic clipping or endoscopic coagulation of the bleeding vessels. So bleeding duodenal ulcer directly with the help of endoscopy, we put adrenaline, clip or coagulation of the bleeding vessels. If it is failed, what are the indications of surgery? Indications of surgery in a bleeding duodenal ulcer are: number 1, failed endoscopy. Failed endoscopic intervention for more than 2 times. There are 2 times endoscopically it was tried, it was failed. So it is one indication of surgery. So failed endoscopy for more than 2 times is one indication of surgery. Number 2, rare blood group. The patient is having a rare blood group. 3, patient is hemodynamically unstable. Hemodynamically unstable patient. Okay, hemodynamically unstable patient. And patients who had severe bleeding and we have done so much of blood transfusion has been done. So please remember, we have to do surgery if there is so much of bleeding and the bleeding is not stopped. The bleeding is not stopped in spite of more than 6 units of blood transfusion, 6 units of blood being transfused. So in this you have to remember 2 numerical values. Failed endoscopy for more than 2 times is one indication. More than 6 units blood transfused on admission, or more than 3 units transfused daily per day is being transfused. We are transfusing 3 units per day. So these are the important indications. Failed endoscopy for more than 2 times, rare blood group, hemodynamically unstable patient, more than 6 units transfused on admission and more than 3 units per day are the indication of surgery. In these patients what we do is simple treatment, directly do laparotomy, open the duodenum like this, horizontally open the duodenum. You can identify the bleeding vessel like this. The gastroduodenal artery will be there and there will be pancreaticoduodenal branch will be coming like this. So open the duodenum and do ligation at 3 point like this. 3 point U ligation will be done. 3 point U sutures are made. If this is the artery, make a suture above, make a suture below, and there will be one branch going, make a suture for that branch also. 3 point U suture will be done. And after doing this, we will do horizontal closure of this duodenum. After closing this bleeding vessel, we will close it horizontally. The opened up will be closed horizontally. And if the patient is stable, we can also do at the same time truncal vagotomy also. If stable, if unstable, just arrest the bleeding vessel alone. If patient is stable, the patient is stable simultaneously, you can also do truncal vagotomy with the Hinkie liquid spironoplasty. So please remember the management of bleeding duodenal ulcer. So management of bleeding duodenal ulcer is endoscopically we have to put injection adrenaline, clip for coagulation. And failed endoscopy more than 2 times, more than 3 units blood per day, more than 6 units of blood on admission. All these cases will go for surgery. 3 point U ligation surgery. So the next complication, perforation. I hope as house surgeons you would have seen so many perforation being operated in your hospital. Perforation patients are easily diagnosed with the basic clinical features. What are the clinical features? They will have guarding and rigidity. So the patients are diagnosed with the guarding, rigidity on examination, and there will be obliteration of liver dullness. Because of air over the liver purpose, there will be obliteration of liver dullness can be found. So these are all classical features: guarding, rigidity, obliteration of liver dullness, and there will be Hippocratic phases for the patient. Hippocratic phases. The patient will be having a dying phases. Hippocratic phases will be seen in the patient. All these findings are seen clinically, and you will diagnose this by taking an X-ray erect view. X-ray, chest, and abdomen. X-ray erect view. If you take X-ray chest and abdomen erect view, you can see what finding. You can see air under diaphragm. Million times asked question. Please don't forget air under diaphragm is a classical finding in the case of duodenal ulcer perforation. So air under diaphragm will be seen. Even 1 ml of air can be diagnosed on X-ray. Please remember, just 1 ml of air can be diagnosed on X-ray, and the sensitivity of this test is 70%. 70% of the time the air under diaphragm can be diagnosed. So what is gold standard investigation to diagnose perforation? Gold standard, which is 100% sensitive. And tell me, if you want to diagnose 100% sensitive is CT scan of abdomen. CT scan abdomen is the 100% sensitive investigation which is diagnosed by a CT scan. So X-ray erect will show you 70% only, but CT scan will show you 100%. So please remember, if the patient cannot stand erect, what X-ray will you take? X-ray left lateral view. We have to make the patient lie down on a left lateral, and we have to take X-ray in which we can diagnose 10 ml air. 5 to 10 ml air can be diagnosed on a lateral view. Okay. So certain questions from this air under diaphragm, let me tell you, from sub-assistant may not be asked for PG, just for understanding and telling. There are some interesting signs from radiology. So presence of air like a mustache like this in a perforation. Presence of air like a mustache like this. What is this sign? This is cupola sign in a perforation. Cupola sign. Presence of air like a mustache. And this is bubble. Presence of air inside as well as outside. This is known as double wall sign, known as Riegler sign. Presence of air inside the bubble loop as well as outside. That is known as Riegler sign. And this is cupola sign. And there is huge amount of air under diaphragm like this. What is the name of this sign? This is known as football sign. Football sign. So football sign, cupola sign, Riegler sign are all findings of air under diaphragm. All these are findings of air under diaphragm. How many percentage of them will have air under diaphragm on X-ray? It is 70%. 30% will not have air under diaphragm. 100% sensitive is therefore CT scan of the abdomen is the 100% sensitive investigation. So such cases of perforation should be shifted to theatre immediately with resuscitation going on. There will be resuscitation going on, and shift them to OT. Shift them to emergency OT and do emergency laparotomy. Lavage should be done. Complete wash of the septic fluid in the abdomen should be washed out. And identify the perforation. After identifying the perforation like this in the first part of duodenum. If the first part of duodenum we have identified the perforation, now we have to do closure of that perforation by various techniques. We have to close that perforation. Okay. If the size is, this is from sub-assistant. If the size is less than 1 centimeter, small hole perforation, we can directly close it. Directly close. Directly close with the help of what sutures? Using polyglycolic acid. That is Vicryl. We can use direct closure, polyglycolic acid. If the size is bigger, more than 1 centimeter, or it is bigger, we use omentum like this. We keep the omentum like this on the hole and fix it with the help of Vicryl. So omental patch known as Graham's patch. Graham's patch closure is done. And the size is more than 1 centimeter. The size is very big, like more than 3 centimeter. It is very dangerous because such a very huge perforations may go for duodenal fistulas. Such big perforations, what we do is we will do pyloric exclusion procedure. That is, we close the antrum like this with the catgut sutures. Using catgut or Vicryl, we close the pylorus like this from inside, and we keep omentum or jejunal patches kept like this. Jejunum is attached like this. Jejunal serosa is done like this, and we will do a GJ. We will do a GJ. This is for mega ulcers like more than 3 centimeter ulcers. We will do this. Okay, please remember, for less than 1 centimeter small duodenal ulcers, direct closure. For more than 1 centimeter size, Graham's patch closure. For more than 3 centimeters, we have to do pyloric exclusion procedure. Pyloric exclusion procedure, and then we have to do a GJ. This will prevent duodenal blowout. So please remember, these are the options for perforated duodenal ulcers. But whatever it may be, you have to do pakka lavage. Wash the peritoneum with the fluid clearly and keep it drained. And keep it drained like this inside the peritoneal cavity. So what are the treatment of each ulcers we are discussing now in detail. And for GOO, you all know very well, this is your exam case, gastric outlet obstruction. Patients with a peptic ulcer, we will do only one operation, that is truncal vagotomy and Gastrojejunostomy, what we have already discussed. So truncal vagotomy with gastrojejunostomy is done for patients who are having gastric outlet obstruction directly. So as a consolidation, let me tell you all the treatments between duodenal ulcer and gastric ulcer management. Let us discuss one by one. So first point, intractable duodenal ulcer. What I told you, the treatment, surgical treatment for intractable duodenal ulcer. I told you for intractable duodenal ulcer, surgical treatment is high selective vagotomy is better answer than truncal vagotomy with GJ. For gastric ulcer, I told you 1, 2, 3, 4 separately like this. So for 1, what I told you for intractable gastric ulcer, wedge resection. Wedge resection. 2, what I told you, 2 and 3 we should do truncal vagotomy plus distal gastrectomy plus Billroth 2. For 2 and 3 we have to do truncal vagotomy plus distal gastrectomy plus Billroth 2. For 4, what you should do? There are 3 procedures I told you: Pouchet, Kelling-Madliner, and Sendi's procedure we should do. Okay, are you clear for intractable complication? Bleeding complication of each. So for bleeding duodenal ulcer, we do truncal vagotomy, may or may not be done, but main point is with or without. So truncal vagotomy will be done, but main is triple point, 3-point ligation of the vessels of the bleeding vessel, plus or minus truncal vagotomy will do. Either we may do or may not do based on the hemodynamic stability. For a gastric ulcer which is bleeding, we oversew the vessels, oversew the bleeding vessel. Wherever the vessel is bleeding, we will oversew the bleeding vessel. Usually the bleeding vessel in gastric ulcer will be from left gastric artery. Maybe mostly from the left gastric artery will be causing the bleeding source. Therefore, we may ligate the left gastric artery. Perforations. Perforation I told you less than 1 cm direct closure, more than 1 cm omental patch, more than 3 cm pyloric exclusion plus GJ. Okay, pyloric exclusion plus GJ for more than 3 cm. Okay, for pyloric exclusion plus GJ is done for more than 3 cm. So please remember, gastric ulcers with perforation. Gastric ulcers with perforation, what you should do? So perforation. For duodenal ulcer, we do modified Graham's patch. Same way we have to use omental patch for gastric ulcer perforation if patient is unstable. If patient is unstable, just take biopsy and keep omental patch. If patient is stable, we should do distal gastrectomy. Okay, distal gastrectomy should be done if patient is stable. Okay, please don't forget the surgical management of these ulcers. These are very important related to peptic ulcer disease. So we are now discussing in detail about duodenal ulcer and gastric ulcer diseases. So let me tell you a broad outline of these ulcers. Which is common of these two? Duodenal ulcer is most common and gastric ulcer is less common. So most common site is first part of duodenum for duodenal ulcer, and this is lesser curve at incisura. That is what we say as type 1 ulcer is most common. Okay, type 1 ulcer is most common. And I told you duodenal ulcer is due to increased acid production. Since it is due to increased acid, when you eat something, the pain gets reduced. After eating, the pain decreases. Pain decreases on eating. Therefore, if you see duodenal ulcer patient, they will keep on eating and they will look obese. Gastric ulcer on the other hand is due to loss of barrier, loss of mucosal barrier. So loss of mucosal barrier is seen in gastric ulcer. Therefore, if you see, when you put something into the stomach, that will go and irritate the raw area and it will cause pain. Therefore, pain increased on eating. So they won't eat. Therefore, they will keep on vomiting. Vomiting decreases pain. So therefore, these guys, if you see, they will be very thin, slim and thin. So they will vomit. And when you go and see these cases, they will be very thin. Vomiting decreases pain. Okay, please understand these points. And periodicity. Periodicity is a classical feature of duodenal ulcers. There is no such periodicity in gastric ulcer. You can see duodenal ulcer usually seen more in the winter time because people will not drink more water in the winter time. So they will have increased acidity and pain. So periodicity is classical of duodenal ulcer. So therefore, please remember, these guys are obese, these guys are thin. And when you go for incidence of bleeding and melena, so melena and hematemesis ratio. Melena is to hematemesis ratio in duodenal ulcer is 40:60, and in gastric ulcer is 60:40. So gastric ulcer will cause more hematemesis than duodenal ulcer. Okay, so malignancy never happens in duodenal ulcer, but there is 0.5% to 1% incidence of malignancy in gastric ulcer. So please remember, 0.5 to 1% incidence of malignancy is seen in gastric ulcer patients. Okay, these are the important points you should know from duodenal ulcer and gastric ulcers. Let us see some of the images. So far what we have discussed. So please remember, this is H. pylori helicobacter having Lophotrichus flagella. You can see it is freely mobile and it is inside the gastric epithelium. So this is a test which I usually do in my clinic when I do endoscopy. On endoscopy, if you take biopsy and put it on the slide, you can see the pink color means it is positive. Immediate result is obtained. This is the investigation of choice when you do invasive test. Okay. So this is the most common point you should not forget. Perforation of peptic ulcer. You can find out this question has been asked more than 100 times in the image-based question section. So 100 times asked question, air under diaphragm. Okay, air under diaphragm. So this is a picture from Barian Love. Hippocratic phases. The patient is having a dying phase due to peritoneal shock. Okay. So at this point, I want to tell you some important basic points from peptic ulcer complications. Most common cause of death in peptic ulcer is bleeding. Most common complication of gastric ulcer is perforation, duodenal ulcer is bleeding. So for gastric ulcer, the most common complication is perforation of gastric ulcer, and for duodenal ulcer it is bleeding. And the most common complication requiring surgery is a repeat question. So please don't forget the common complication requiring surgery is bleeding. And don't get complicated with this question. Complication with highest mortality rate is perforation. They are asking which is the most common cause of death. The most common cause of death is bleeding. But which complication carries highest mortality rate is perforation. The perforation causes 15%. For example, 100 people develop perforation, 15 will die. But 100 people developing bleeding, the incidence of death is not that much. The problem is there are thousands of bleeding, therefore there are more deaths due to bleeding. So please don't get confused in this. The most common cause of death and most common indication of surgery is bleeding. Okay. So this is double wall sign, presence of air inside and outside the bubble. This is a perforation. And this is olden days deformity due to chronic gastric ulcer going for hourglass deformity. There is one more deformity also. This is hourglass type stomach causing GOO. There is one more deformity known as teapot deformity. These are all not seen nowadays. These are all just for historical questions. Teapot deformity, hourglass deformity are all old questions. Nowadays we cannot see these patients in practice. So these are the operations I told you. This is Pouchet. This is Kelling-Madliner. This is Sendi's. After these operations we do Billroth 2 reconstruction. Okay. So this is high selective vagotomy which should be done 7 cm proximal to pyloric orifice.